Good morning, everyone. Thank you for joining us for the webinar Addressing Vaccine Hesitancy, Evidence-Based Strategies to Increase Acceptance, and backed by popular demand because this is the second webinar done by our presenter today. My name is Megan Clark, and I am the Research and Evaluation Lead with the Saskatchewan Prevention Institute, and we are hosting this webinar. The Prevention Institute works in many different areas related to child health and well-being, so I encourage you to visit our website at skprevention.ca to learn all the ways that we can support the work that you do. The Saskatchewan Prevention Institute provides services to all those living on treaty lands 2, 4, 5, 6, 8, and 10, the ancestral territories of the Nehiyawak, Nehithawak, Nehinawak, Anishneabek, Nakawe, Dakota, Lakota, Nakota, Dene, and the homeland of the Métis. And I apologize if I mispronounced any of those. I'm still working on that. So we recognize that these lands are currently inhabited by Indigenous people from across Turtle Island, including many other First Nations and Inuit peoples, and acknowledge the importance of the treaties, the lasting impacts of colonization, and continued inequities. We are dedicated to moving forward on a shared path of reconciliation and partnership. We are all treaty people and are grateful to live, work, and play on this land. So there are just a few housekeeping details that I'll quickly mention. First of all, the webinar is being recorded, and we heard it come on at the beginning, so we know that's true. All attendees are muted. Feel free to put your comments in the comments section. And if you would like to let everyone know who you are, where you are, and your role, that would be great. And if you have questions, please put those in the Q&A box so they don't get lost in the comments. So our speaker today, Dr. Noni MacDonald, is well recognized in Canada and internationally as a leader in pediatric infectious disease and vaccines. She has published over 500 papers, and her research is highly cited. Dr. MacDonald has received many honors, including recently being inducted into the Canadian Medical Hall of Fame. So needless to say, we are very pleased that Dr. MacDonald has graciously agreed to provide the webinar today. So I'll hand it over to you, Dr. MacDonald.
Thank you. A couple of points I want to make before we begin on the topic. First, I live and work in the notice I said unceded territories of the Mi'kmaq people. I recognize and reflect the Indigenous knowledge held by the Mi'kmaq people and the wisdom of their elders past and present. The Mi'kmaq people did sign a peace and friendship treaties with the Crown, and Section 35 of the Constitution of 1982 recognizes and affirms Aboriginal and treaty rights. We are all treaty people. But these truly are the unceded territory of the Mi'kmaq that I'm speaking from. Second point I want to make is I have no financial interest to declare. I'm a professor emerita at Dalhousie University, and Dalhousie pays my pension. The third point I want to make is, for those of you who might have heard me when I presented this earlier in October, I can never give the talk exactly the same. So if I say something slightly different or frame it a little differently, it's because that's how my mind works. So this will be the slides from the talk I gave on October 22nd, but it'll be with today's version of it. Big point I want to make here to begin with is in August of 2020, the World Health Assembly passed the Immunization Agenda 2030. Canada was one of those 194 countries that signed on to this, so we are accountable to this too. The main piece in Immunization Agenda 2030 is that everyone, everywhere, at every age, fully benefits from vaccines for good health and well-being, with no one left behind. So why are immunizations so very, very important that the World Health Assembly actually spent a great deal of time talking about this Immunization Agenda 2030? So it's estimated that by 2030, due to immunization, there'll be 51.5 million deaths averted due to immunization if we can grow the way we would like to grow. Beyond that, I'm sure everyone on this call has heard about our whole problem with antimicrobial resistance, and we're having more and more costs because of that. We have to use fancier and fancier antibiotics. People are in hospital for longer periods of time, and we've had lots of deaths. Well, vaccines can also decrease the deaths and the costs of AMR. How? 44 vaccines, current and new ones coming down the pipeline, are against 24 pathogens where we use them to treat with antibiotics. And even if we use these alone, we could decrease by 500,000 deaths a year on top of the others we talked about. It would also save billions of dollars. It's estimated 60 billion for healthcare costs, and for antibiotic use, decreased by 22%, which decreased the pressure on the microbes so they stop evolving and becoming so resistant to the antibiotics we use already. So I don't have Canadian parallel data because we haven't done it in this way. This is the US estimated prevented illnesses, hospitalizations, and deaths per thousand in children 1994 to 2023. And as you can see, if you look at the bottom where I've boxed it in red, a lot of illness prevented every year, a lot of hospitalizations every year, and a lot of deaths every year. And the data would be similar in Canada. We need vaccines to save lives, hospitalization costs, and illnesses. It's more than saving lives. It also grows our human capital. Children are healthier and therefore they get a better education. They stay in school longer. We grow a healthier workforce that increases our productivity, both physically and mentally. It decreases fertility rates. No, not due to the vaccine itself, but you have smaller families because the children are surviving. And it's very successful. We see that in more successful populations. So if you go back to the turn of the last century in the early 1900s, many families had 10, 12, 15 children because a bunch of them died, and a number of them died from now vaccine preventable diseases. So vaccines have a health impact, keeping people out of hospital, economic impact, and a societal impact. Going back to what the whole talk is about, how to increase vaccine acceptance, vaccine decision making is complex. When I give you a fact, if it agrees with your belief, you will hear me. But if I give you a fact and it doesn't agree with your belief, it just doesn't even get in there. So what we have to often do for vaccines is we need to reshape that fact and package it so people can hear it when it is not as per their beliefs. Risk perceptions are intuitive, automatic, and unconscious. We don't even know we're doing this. Emotions play a role in how people make decisions. If I'm anxious, if it's scary out there, I'm going to make a decision differently than if it's calm and peaceful. And emotions also play a role in how people interpret numerical information. So, as I said, vaccine acceptance is very complex. Our lived experiences matter, including historical and present day discrimination. We're strongly influenced by what we think those around us are doing or expecting us to do, our social networks. We see causation in coincidences. We think just because something happened after the event must have caused it. That's why we have so many things. Well, this happened after I got vaccinated, therefore it's due to the vaccine. Talk quite a bit about more about that later. We see what we believe rather than believing what we see. We often prefer anecdotes and stories to data and evidence. We're influenced by whether we perceive the disease as a threat. So one of the challenges for vaccines are vaccines have prevented many, many, many infections and many deaths. And so the disease doesn't even look serious anymore. That's not true. Polio is still polio, is still polio. We pay much more attention to negative information. This is built into us. This is why we survived over the millennia. When you saw something that was bad and you were told that was bad, you didn't do it. So hence, safety concerns and lack of trust may be very prominent and may very much affect how we make our decisions. And access may be difficult or may be seen to be difficult. So how do we define vaccine hesitancy? This was first done in about 2015. It's the delay in acceptance or refusal of vaccines despite the availability of vaccination services. You cannot be hesitant if you can't get access to the vaccine? It's complex, it's context specific, it varies across time, place, and vaccine. It's influenced by such factors as conveniency, complacency, and confidence, at that time called the 3 Cs. We know in high income countries, there are only less than 1.5% are true vaccine deniers who refuse any vaccine with conviction. But there are somewhere between 10 and 20% who are indeed hesitant. So there are many, many, many ways that we have explained vaccine hesitancy, and a ton of research has been done on this. The 3C model, the confidence, complacency, and convenience, morphed into a 5C model, which then more morphed into a 7C model, which you're seeing up there in the corner. There was a 5A model that came out in 2016: access, affordability, awareness, acceptance, and activation. And then WHO in 2022 or 2023 came out with the behavioral and social drivers of vaccination. And they put them into thinking and feeling, social processes, motivation, practical issues, and vaccination. And they have a very good booklet that you can download, report on all of this. It's a tool. You can use it to monitor vaccine acceptance within and across social contexts, and then assess the impact of the interventions that you're doing. It's quite complex, but it is very thoughtfully done. During COVID, when I chaired for the Royal Society of Canada, the COVID vaccine acceptance working group, we looked at all of these models and said, lots of good stuff here, which is why we've got the multicolored pieces up there. Immunization, accurate and reliable knowledge, healthcare workers, both regulated and unregulated workers, and people in place. What's the context? What's the culture? What are civil societies doing? But we added in this purple box, which we think is incredibly important. What are the healthcare and public health systems? What are you doing at the federal level around vaccines? What are you doing at the provincial and territorial level? What are the policies? What are the programs? What are the practices? And what are the politics? Is your premier supporting vaccination, or kind of on the edge on it, and doesn't actually think vaccines are that important? That totally flows down to what resources are made available, how much immunization knowledge is out there, how healthcare workers are supported or not supported to give vaccination, et cetera, et cetera, et cetera. So we think it's an incredibly complex thing that has all of the components that are in this WHO one, but we think you have to add in this political piece into the whole discussion. This was a study by Xu, who really showed vaccine hesitancy and uptake is so complex. They looked at all of these factors in the US: racial and ethnic groups, industry, socioeconomic, health related, housing type, demographics, partisanship, and state fixed effects, and showed they totally all affected immunization uptake. I don't know if you know, but for COVID vaccine in the US, there was much less uptake of COVID vaccine among those who voted Republican versus those who voted Democrat. Needless to say, there were more deaths among the Republicans than there were among the Democrats because they didn't get vaccinated. So what I've done here is try to divide the common barriers to vaccine acceptance. Notice I didn't say hesitancy. It's more complex than that. To structural, behavioral, and information barriers. I'm going to talk about all of those and look at some of the strategies we can use to address them. Structural first. Here are the common structural barriers: federal, provincial, territorial political decisions. Are they going to fund vaccines? At what level? Are they going to use a process for purchasing, which means we get them at a much better cost? Or is it individual self-pay, or is the government paying? And even if it's individual self-pay, it's not free, okay? Because I may have to take time off work, I may have to pay for parking, all of those kinds of things because of where I can go and get it. Personal anecdote for myself and my husband: I am over 70 years of age. NACI has recommended the RSV vaccine for those over 70, but in my province of Nova Scotia, it is only funded for those who live in long-term care facilities, which I don't. So I am paying for it myself and I'm getting it tomorrow. Ease of access includes physical barriers. Where's your clinic located? What are the hours of operation? Do you need to book an appointment? Does it have to be done online? Can it be done by phone? Can you do drop-in where you don't even need an appointment? How far is it? How hard is it to get there? What about parking, as I said before? What about those who can't leave their home, that have they're homebound? How is your infrastructure supporting them? Our poor infrastructure often means we try to do one size fits all, and that doesn't work. We also are missing data. We don't know necessarily among our populations who's had no zero dose, no vaccines as an infant or young child in real time. So we could try to catch them up before they're older. Who missed doses and why did they miss those doses? And then we have healthcare workers who themselves are not up to date. They may not have had all the training that they need. And then we have the care system barriers. We have stockouts, both stockouts and cold chain. So I know in Saskatchewan, it gets very cold in January and February. I've been there during those times. When it's that cold, some of our vaccines can't be frozen or they're damaged, like MMR. And because of that, our delivery and our getting the vaccines out to the places where they need to go has to be done with great care. In countries in the equator and even in the summer here in Canada now, because it's getting much hotter, we have vaccines that have to be kept below 8 degrees centigrade. And if they rise above that, they are not effective. So we have cold chain problems and hot chain problems. We also have healthcare worker stockouts. We may not have enough people who can immunize, and that's a problem for us. And then, what's your past experience with the health system? Was it welcoming to you, or did they kind of ignore you or disrespect you? What about language and culture? And how welcoming are the healthcare workers when you do come in to get immunized? This is just a couple of examples to look at. Vaccines in pregnancy. We know we have low uptake is not necessarily related to high vaccine hesitancy. There are many other reasons. One of them is that we often don't have data on how best to use vaccines in pregnancy because they were not included in phase 3 trials of vaccines before they came and were approved and authorized by FDA in the US or Canada with Health Canada. During the pandemic, when pregnant women were assessed about their ability to access COVID vaccine, somewhere around 21% strongly agreed that physical access was a big issue for them trying to get pertussis vaccine in pregnancy. So we've got the worries because they don't have the data and the mother's going, oh, is this safe? And then we've got the access issues that go with it before. And we know this has caused us problems. There were pregnant women who died of COVID because they didn't get COVID vaccine, not because it wasn't available, but they were frightened to get it because there wasn't the data on safety available. This is an illustration of why pregnancy is such an important issue. COVID vaccine in pregnancy much decreased COVID hospitalization for infants, hugely under a month, 1 to 2 months, and 3 to 5 months. So it's really important that we did get the COVID vaccines into the pregnant women, and we didn't do as good a job as we could because of many of the barriers that I spoke about a few minutes ago. Then I'm going to shift now from the structural barriers to the common behavioral barriers. Data, why you're not immunized or under immunized, where and what catch-up programs have been tried, and why did they fail if they failed? Because we need to know that to go and find those zero dose children or zero dose adults or older children who've missed their school immunization, etc. Common behavioral barriers, forgetfulness. How easy is it to book that appointment? What about language? What about computer literacy? How do you actually do it? Can you just drop in? Do I have to make an appointment? But we do know if I had to make an appointment that reminders both at the individual level, the parent or caregiver level, the provider level, pregnant women, and all of those people who have missed doses, if I remind you that you need to do this and I nudge you, it does make a difference. I'm going to show you some data in the next slide. Spirituality can contribute to skepticism in science. Often low science literacy needs to be addressed and we need to listen and address the concerns that people have about vaccines. The major religions of the world, all of them support immunization. And the faith is a complex system, and often the faith leader, by supporting immunization, can increase uptake by speaking about it within the religious site. And in COVID, the Canadian Public Health really tried to work with religious leaders across the country to have them speak out about immunization and how important it was. And that was a way of reaching a number of people and influencing them in a positive way, nudging them to accept vaccine. Here's the reminder letters. This was a study that was done in Denmark. Any letter, it didn't matter why the letter was done, whether it was loss framing letter, implementation to prompt you to do this, respiratory, again, letter, your lungs are going to be better letter. It didn't matter. In all cases, this was for influenza vaccine for patients with chronic diseases. In every single one of these cases, if you got a letter, you are much more likely to come forward and get immunized. The point of this is cheap. This is not an expensive intervention, and yet it significantly improved vaccine uptake among those patients with chronic diseases. Aha, we have a problem that Denmark doesn't. We don't know often in public health and even within the healthcare system who all has a chronic disease that really is increased risk for influenza and therefore needs to be nudged to get the flu vaccine. We don't have that data. It's not in our immunization data sets. Who's got it is there, but often their medical information isn't tied and linked to this. So it makes it very difficult to do what they did here in Denmark. And I wish we could fix that. I've been advocating to fix that part of, and join the healthcare system data up to the immunization system so we could do this. Do you know in Canada, today, I could not ask the question, how many people do we have in Canada who have diabetes type 2, one of the groups that would be recommended for this, and how many of them have been immunized and how many of them have not? They could do that in Denmark. Wish we had that kind of system. We also knowing that working collaboratively with our partners to have that voice come out to say how important immunization is really helps. So who are your partners? It, your public health, but it could also be academia, healthcare professional societies, such as the Canadian Medical Association, Canadian Pediatric Society, and on, nurses associations, civil society organizations, religious leaders, trade unions, global agencies who support immunization like UNICEF, private sector businesses, and sometimes even sports teams will support immunization. And we need to have all of those coming forward and encouraged to put their voices in support of vaccine acceptance. It enhances credibility and it enhances the message that healthcare workers putting out there. One of the things that I meant to add in because it only came out after this, Nigeria has they took their a number of their very popular singers and music makers, and they wrote a song that's really catchy and it's like an earworm. And that has been two things. One, those people support immunization. Oh, I look up to those people. And two, that little earworm from their songs catches me up. Have I done this? Do I do it? And I think we need to be thinking about this on a provincial and national level to try to see how many of our organizations we can have step up and could they do this in a pretty original way. More barriers, inertia. Oh, it's hard to change. All right. And one of the things in making change is I need to trust the person who's coming to talk to me about change. So that would be healthcare workers. I'm going to talk about that in a minute. But what do I mean by the word trust? There are two parts to trust. It's about your competency, how much you know about vaccines. But even if you are super competent, they'll respect you, but they may not trust you, because trust also involves that other part, the caring part. But if I show I really care, but I don't know much of the information because I'm incompetent in that and not trained up, I won't get trust either. I need both of those two parts to get trust. So it should not surprise you that the strength of a healthcare worker's recommendation is very influential. In fact, it's often the most influential uh, for in a person deciding to accept vaccines, because healthcare workers should be knowledgeable and they should be compassionate. So we have the credentials to be able to do this. Now, but it's important that all healthcare workers are up to date on the vaccines and knowledgeable. They need to know about safe delivery and how to optimize communications. We also know a healthcare worker's own immunization status reflects on their patient's immunization status. That should come as no surprise. If they're not keen on immunizing themselves, getting themselves immunized, why are they going to be super keen on doing it for their patients? We can nudge healthcare workers to get immunized and increase the number that are up to date. We need to be aware, not all healthcare workers support immunization. They don't all know how to counsel positively about vaccines. They don't all know that you need to be knowledgeable, respectful, and do this in a very positive manner. But we do know that educating healthcare workers about vaccines and strategies that work can increase uptake substantially. During COVID, there was a study among healthcare professionals in the US and Canada in 2021. And while all healthcare worker vaccination or intended vaccination, many, they were going to do this, but they were actually uncomfortable discussing COVID vaccines with patients because they weren't sure what they should be saying. That's why education is so important for healthcare professionals. So we also, beyond that part, we need to use the most effective discussion techniques. We need to start with presumptive statements. It's your time to get flu vaccine this year, Mr. X, who's got heart disease. It's your time because you're a year old to get your MMR. We don't want to do this as a default. That we want this to be so you're motivated. This is what everybody's doing. We don't want to do it as, well, what do you what do you think? Do you think you should get a vaccine today? What's your opinion? It's not how we should do this. We need to be presumptive. This is the behavior that everybody is doing. We need to open the door for questions and queries. It doesn't mean we're not going to do that. And we need to use what's called motivational interviewing. And this is a quick rundown of that. We use open-ended questions. What do you think about vaccines? We need to listen reflectively. Oh, I hear you're concerned by likely vaccine safety. We need to affirm and validate. I understand. And then we need to say, we need to ask and provide and verify what you know and provide the vaccine information that fits what their concern is and verify that they understand what you've said. And then we do something super important. We summarize. Why do we summarize? If you were under 5 years of age, and you would not be listening to me if you were, you would use verbatim memory recall. You would hear exactly what I said, word for word for word. And that's because in 3 to 4 year olds, that's what they do. It's why they'll have heard their parents say something and then they come out in a completely inappropriate setting and parrot exactly what their parents said. We don't do that once we're 5. We actually only store gist. What was the summary of what I heard? What was it about? And that's why we want to summarize so they can hear it well. And at the end of this, after I've summarized, we need to add freedom establishing wording. Of course, it's up to you, or the choice is entirely yours. You are free to make this decision. By then, hopefully, with motivational interviewing, you've already persuaded them that this is a good idea, but this is a compliance gaining technique that has been shown to work really well. Does motivational interviewing work? You bet your britches it does. And we've used this. I was part of a study here at the IWK across Canada. We were doing this in the first 48 hours after the baby was born. The mother received a visit 5, 8 minutes on the value of vaccines and the importance for their baby. This is the time when the mom is falling in love with their baby and really wants to do what's best for their baby. We had control group who didn't receive the same thing versus these group. And at 3, 5, and 7 months, the vaccine uptake was up for the 2, 4, and 6 month vaccines. This works. 5 minutes, done right. We need to use effective, clear language, standard vocabulary. You all know what a rare steak is, but a rare side effect is between 1 in 1,000 and 1 in 10,000. And most of our serious side effects aren't even in that range. They're in the very, very, very rare, like 1 in a million. All right. But so when we use that term rare, we end up confusing people. We need a consistent denominator so people can compare the disease complications versus this concerns with vaccines. We need to tell the truth, present risk and benefits fairly, be transparent about uncertainty. We don't know that yet. This research is going on. We need to explain single event probability. It's raining, it's not. You're dead, you're not. And we need to use visual aids. That's why I showed you here's 1,000 children. Tetanus, 10% will die even if they're in the ICU. It's 100 in every 1,000. And visually, that's more clear than if I do them as a percentage. BCCDC has a great document that you can download with a lot of these clear, effective language techniques with examples for you. The other thing you need to do is don't use relative risk. Most people can't explain relative risk unless you're an epidemiologist. Use absolute numbers, 100 out of every 1,000. Okay. Fact sheets, ensure that they're readable and they have infographics. That'll often stick better than just the words. Avoid using jargon. Oh, we in medical care and healthcare, we use jargon all the time and we think everybody understands it, and they don't. We need to frame and time the message. I'm going to talk about that more in a few minutes. Negatives are heard much more loudly. Remember, I told you negative stuff sticks? It's a problem for us. What do you do in informal settings when colleagues, friends, family, or loved ones are vaccine hesitant? Well, if you stay silent, everybody around you thinks you're agreeing with that person who's being vaccine hesitant speaking up. Not a good thing. You're not likely going to change that vaccine refuser's ideas, but the people around them you may be able to influence and or raise questions. So you need to speak up. You need to acknowledge that there's lots of misinformation and disinformation out there. You need to highlight techniques being used in disinformation. Here they are on the side. These 6 are the big techniques they use over and over and over and over. Conspiracy, fake experts, selectivity. They take a tiny little piece out of a research thing and not even give you the context in which that was found. Impossible expectations. Well, that vaccine has to be 100% effective, no cases afterwards, and no side effects, and no risk. You know what? That's impossible. Getting out of bed every day has a risk. You might fall and hit your head on the floor. There's nothing in life that doesn't have a risk. Impossible expectations are done to help confuse people and move them away from understanding the value of vaccines. Misrepresentation and manufacturing of doubt, pulling out little pieces of disinformation, actually false information, and making it seem super important because it's repeated over and over. Logical fallacies. After it, therefore, because of it. I have to tell you this one because this one drives me nuts. You know, this is more than almost 20 years ago now, more than 20 years ago. In 1999, there was a paper that was published that said MMR caused autism. Actually, it was retracted because it was fraud. It wasn't even good science. But people have kept that. Well, my child got autism after they had their MMR, therefore MMR caused it. Let's talk about that in a slightly different context to show how that's a logical fallacy. When did children learn to walk? Between 10 and 18 months. So, if that child learned to walk a week after their MMR vaccine, did the MMR vaccine teach them to walk? And we'd all laugh. Same fallacy as it was for autism. It's because autism was diagnosed most commonly 18 months to 2 years of age, simply because that's when there was enough signs and symptoms for people to pick it up. It had nothing, zero to do with MMR. But it has taken millions of dollars to refute that logical fallacy. And they keep coming up. We need to highlight the techniques that are used, as I said. We don't get into a debate with these people. We need to state the evidence and the science and how important vaccines are to prevent diseases that are still serious. And remember, if you've seen a patient with one of these vaccine preventable diseases, it's often more powerful than a story to talk about what it was like with that patient. And some people have talked about taking vaccine selfie pictures. You know, here I am getting my flu vaccine or my COVID vaccine or whatever one it is. This is about fire fighting and fireproofing. We're going to talk a bit more about that when we talk about information. Other barriers, common behavioral barriers. Whoa, as I said, inertia is hard. Doing nothing is easier. Okay. So, how do we do that? How do we decrease that inertia, help overcome it? Ease access, make it so simple. Reinforce vaccine acceptance action is the norm and address concerns that they have. The top 3 reasons globally around the world in vaccine hesitancy. Number 1, risk benefit, the concern about vaccine safety everywhere, every year when we looked. Lack of attention to safety concerns by the healthcare worker who wants to immunize can really undermine what you're doing. You need to understand and address these concerns. We also need to better educate the general public, and we need to communicate well. Here is an example of willingness to receive a vaccine, totally influenced by adverse events following immunization. Indirect exposure to an uncommon or very rare adverse event. Oh, yeah, that decreased your vaccine acceptance. Indirect exposure to a scientifically unsupported AEFI, like autism after MMR. Yes, that decreased vaccine acceptance. And then injection anxiety, worrying about getting that needle, decreased vaccine acceptance. Talk about that in a bit more. Am I making this up? No, I am not. Negative information sticks. All those safety adverse event concerns stick. Framing it must be done in a positive way. We know because there's studies now to show it. For HPV, for example, HPV vaccine, it's way better to say it's 99.9% safe than to say it has less than 0.1% serious side effects, which is true. It's actually 99.99% safe. Okay. Here's the study over here for the UK, different one, but the same kinds of questions. This UK study looked at the value of immunization programs for newborns and children as well as adults. In all age groups, averting the side effects was very important. It was 3 times more important to avert those side effects of the vaccine than averting the infection in the child. Think about it. And 6 times more important in the adults for those 65 to 75 years of age. They were more concerned about potential, very rare, serious side effects than they were about the serious side effects of the disease. We have to make sure they understand the disease risks and how safe these vaccines are. Then we need to deal with pain. Okay, why? At least 10 to 15% of adults fear needles. I wish I could see all of you and you could raise your hands and tell me how much of you enjoy getting a needle for yourself. And for children, it's up to 30%. And it's a big contributing factor to vaccine hesitancy. We have pain reducing techniques for all age groups, from neonates up to the elderly, that are proven, evidence, randomized controlled trials to decrease the pain of immunization. And decreasing the pain of immunization is an important decreaser for immunization stress related responses known as ISRRs. ISRRs can occur in clusters where one child at an immunization school clinic goes, ooh, 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 and faints, and then everybody else starts to faint when they can see that child. You can also get pseudo seizures. Again, it's a stress reaction. It's not actually due to the vaccine. It's due to the stress of getting the needle. ISRRs are common and we need to deal with them and prevent them. You can decrease it with a clear explanation about immunization and how you can decrease your anxiety around that needle. Calm, confident delivery. You can do muscle tension. And there are steps to decrease pain called CARD: comfort, ask, relax, and distract. They work. We have RCTs in long-term care facility with demented patients. It works. Important slide, which I hope you'll remember. This was a study that was reported about the COVID vaccine, the Moderna vaccine, but that's not what I've pointed out to you here. I want you to see the non-specific effects that happen even with placebo when I stick that needle into you. Pain. Yes, it was more with Moderna than it was with the placebo, but it still happened with the placebo. And look at the rate in 2 to 5-year-olds, almost 40% with the placebo. Okay. Yes, more with the vaccine, but high rates with even with placebo. I cannot, when I'm stressed, make my arm swell up. I cannot make it go red. Okay. Those are not immunization stress reactions. Pain is. I can also have fatigue. And look at this. Look at the fatigue rates among the age groups from the placebo, not even the vaccine. Headache. When I'm stressed, I can get a headache. 29% versus 35% if I was in the 18 to 64 age group when I got the vaccine. You know, most of it was the placebo effect. I can't generate a fever, but pain, fatigue, and headache are among the immunization stress related responses. We need to understand that and try and prevent those stress responses to make the whole event less stressful and less likely to have those adverse events, common adverse events. The problem for us and for everyone is that it's not usually a single reason why somebody is not accepting a vaccine. This was a study from Manitoba, and it was looking at the Southern Health region. They had low vaccine uptakes even pre-COVID, and they certainly had them with COVID. They're trying to bribe us. This was a study in 2021, and there were 3 drivers of low COVID uptake. Risk perception about the safety of the vaccine. That should come as no surprise now after the data I've presented to you. Religious and conservative views, what religious leaders said or what they did not bother to say. And distrust in government and science. Those were the big ones that were there. Shifting now from behavioral to information barriers. So we had structural, behavioral, now information. You know, this is the third barrier. First, let's look at information engagement. This came from a poster in 2022 by DeVere, and he looked at participation. How invested are you in this information and the information retrieval? Perception. What's your relationship to the information? What's your emotional involvement? Remember, I said before, if we're very emotionally involved, it affects how we see information and how we make our decisions. And perseverance. What's our user retention, quality of integration, and influence of that information? So, the common information barriers Mis and disinformation, I'm going to talk about that in a minute. Lack of adequate information to direct to quality vaccine sites. Do you know what sites to send people to that have information in the language and cultural context that they will understand? Different age groups for immunization. What's the complexity of the information? Does it fit their educational level, their background level? And remember, data tells, but stories sell. So knowing about a child who had been not immunized, who was who was damaged by the vaccine preventable disease is a very powerful story to tell. The Public Health Agency of Canada has these booklets available on Parents Guide to Vaccination. It's available in 14 languages, but even 14 languages is not enough in Canada. It's good. We're almost there, but not enough. And then we get contradictory advice. What our National Immunization Technical Advisory Group, NACI, and what the Information Product Manual say don't always go together. How could that happen? Mis and disinformation. Misinformation is information that's actually false, wrong, but it wasn't created with the intent of causing harm. In contrast, disinformation is false and it was deliberately created to cause harm and to deceive. Economic gain, political gain, you can think of the guys in the United States for that, particular people, or attention, prestige gathering, polarization, splitting people apart. Okay. Does this matter? Whew, yes. This was a study that looked at misinformation, not misinformation in COVID vaccine uptake in the UK versus the USA, specific misinformation that was out there. It decreased COVID vaccine acceptance by 6.2% in the UK and 6.4% in the US. Not a trivial number. Why does fake news stick? Why does this disinformation stick? It's emotional. It taps into people's feelings and casts doubts. It's simplistic. Everyone can understand it. It's comforting. Um, it feels, I don't have to worry so much anymore. All right, in this uncertain world. So some of these misinformations, natural immunity is better. Not if you're dead. Too many immunizations overload the immune system. My goodness, whatever you had for breakfast this morning had more antigens in it than you're going to get in your vaccine. Vaccines have harmful ingredients. Oh, we hear this over and over and over again. It wouldn't be getting approval to be used if those ingredients were in such a high number to cause a problem. Many diseases are now uncommon. I don't need those vaccines. It doesn't matter if every other person in the entire world was immunized against tetanus. It's no protection for you at all. There is no community immunity for tetanus. It's all on the individual level. And the problem is, as many of you know, we have not as high rates of immunization as we need for many of the common vaccine preventable diseases. So our community immunity isn't where we need it to be. There are alternatives to vaccines. I can give you something else that will be better. What? Okay, not likely. We have nothing that will avert polio, prevent polio, except polio vaccine. Look at this Russian troll and vaccine misinformation data. This happened during COVID. There were 9 million tweets on 3,500 accounts during a fairly short period of time. What did they go after? No surprise. Personal dangers, negative outcomes of vaccines, civil liberties. It focuses on personal freedoms and vaccination requirements. You shouldn't have to do this. And conspiracy, sinister actions and actors. It's not in your public interest to get immunized. Think about it. That's what people are hearing over and over and over again. So, what do we do about this mis and disinformation? As I said, they use these 6 techniques. And what we want to do is flatten that curve so that when stuff doesn't get pushed on to somebody else, it doesn't get further spread. Somebody looks at that piece of disinformation and said, this is rubbish, and they don't send it out on their social network to all their friends. What are the other things? How do we do this? Firefighters, fireproofing, and fire marshaling. What do I mean by firefighters? This is you. This is me. This is speaking up when we hear mis and disinformation. We make the facts the hook. Everybody in the world immunized against tetanus and you're not. Tetanus is in our dirt, in our earth. It's all around us. You're only protected if you're immunized. And 10% of people who get tetanus, even with ICU care, die, even with the best care we know. You share data and you tell stories and you try to be as creative as you can be to help people understand the risks of the disease and the benefits and safety of the vaccines. Use humor and emotion. Highlight consensus on science. We know this. This is why we wanted you all to work together. It's called the gateway belief. It garners more belief. If everybody is saying the same thing, that these vaccines are incredibly important, then it's heard differently than if it's one lone voice saying it. Fireproofing, inoculating the public against the mis and disinformation, debunking it. You need to teach critical thinking and media literacy. We need to show the techniques that are used to sell mis and disinformation and how you can counter them. The WHO Euro has how to respond to vocal vaccine deniers in public, and it outlines how you can do that. And it's in the references that are at the bottom. Fire marshaling. I wish I could speak better on this one. Structural changes that are what was allowed on Twitter and X. Unfortunately, that's all been taken out. They can do whatever they want here in North America. The OECD and some of the European countries have been much tougher on this and said, no, you cannot put out this false stuff. I don't know what's going to happen with his nemesis down in the States. I don't think this part is the fire marshaling is going to get any better. What do you do about stopping fake news and its impact? There is, in the digital age, you can download this document. It's full of really good information on how to do this. Improve your communications. How about increasing education and seeking better transparency? So the social media platforms are much more clear about who's saying what about what. As again, I said, I don't think that's going to happen. Not the changes that we need in fire marshaling that I'd love to see. There have been virtual reality chat boxes and stuff. That's more fireproofing. But you know, that's fancy, that's expensive. And we know that you doing motivational interviewing will gain you just as much good stuff. The UK, the bad news game, it's very sharpening. Media literacy skills. It teaches you how to be a Russian troll. And by learning how to be a Russian troll, you can see how effective it is and the techniques they're using, and therefore you get protected. Here are the websites for the game, and it really does work. And there's a junior version for younger kids under the age of 14. All of this helps. And there have been RCTs to show that it does make a difference and helps protect you against disinformation. This one I want to stick. This is Finland, the multi-sector educational proof, fireproofing. They have a K to 12 education media literacy skills. They start in kindergarten teaching media literacy skills to detect mis and disinformation, detect pseudoscience. And the state officials are trained to recognize and combat fake news. They now have the best media literacy scores in Europe. Nationwide, they are ahead of everybody else. Denmark is catching up, and so is Finland and Norway. I mean, so is Denmark and Norway are catching up to Finland. I wish we were in this league, but we are not. We need K to 12 education on this. This is not going to go away, and it's not just about vaccines. We really, really, really need media literacy skills. What do you do when you have unintended misinformation that's complex and contradictory? In our National Advisory Committee on Immunization, they provide information on the vaccines that they're recommending to be used in Canada. But sometimes the NACI information isn't exactly the same as what's in the product monograph that people can look at online. And then what do I do? Which is correct? Well, the regulator, Health Canada, that approves the vaccine language in the monograph that the company puts out, that doesn't get changed unless the company upgrades. So as more information and research comes out, NACI may be changing their guidelines and their recommendations, but it's the product monograph doesn't change. So what do we do about that? So this is what happened, and this is what's in the front of the NACI guidelines now. Read the red part. People administering the vaccine should also be aware of the contents of the relevant product monograph or graphs. Recommendation for use and other information set out in the NACI statement may not agree with what's in the monograph because the monograph is not as up to date as it could be. Okay. And people need to understand that NACI looks at all of the information. The product monograph was put in there at the time they got authorization. We then tried to persuade the companies. This was based on flu vaccine in pregnancy. We tried to persuade one of the companies to see if they would change their language. So GSK did this in 2022, but I have to tell you in 2024, it's not all we would like it to be. They kind of regressed. So they had the standard things that they always say. Animal reproductive studies have not been conducted on flu zone. No. Quadrivalent is not known to cause a problem. Data on use of the vaccine in pregnant women are limited, should be given to pregnant women only if clearly needed and following assessment of the risk and benefits. Well, how is that mother supposed to assess the risks and benefits? And even the family doc that's going to do this should be able to do this, but they don't know all the data. And it's very anxiety provoking when they make this statement that I don't know the safety. That's what it basically says off the top. In 2022, they added this. Really important. However, there is no evidence to suggest the risk to the fetus. No evidence to suggest a risk to the fetus. No evidence. Or the pregnant woman from quadrivalent vaccine, because there isn't any evidence to say it's bad. And NACI states that the influenza vaccine is recommended for pregnant women, and then they give you the reference for both of those that you can click on and do it. I wish we had that all the time. 2024, what did they do? Oh, safety of Fluvone Tetra has not been established in clinical trials because it hasn't. Systematic review of the literature do not indicate an increased risk of adverse pregnancy outcomes. That's good. Animal studies do not indicate any direct or indirect harmful effects. That's good. And it must be administered, may be administered to pregnant women following an assessment of risks and benefits. Why couldn't they have also said, and go look at what NACI recommends? They forgot that part. So where do we go from here? And what are we going to do? Well, we have this problem. We've got structural, behavioral, and information issues. There's no silver bullet. There's no one thing that's going to make it better. What you need to do for the structural ones is think about it in your context. The behavior ones, employ all the techniques we know that work. Information, we need to get on to this mis and disinformation, and we need to make information access for quality information easy. Fit the language, fit the culture, fit the context. And it's up to you to combat vaccine hesitancy and increase vaccine acceptance. Thank you.
Thank you, Noni. That was great. We do have a few questions, and I'll just remind people that if they do have a question, please to put them in the Q&A box, and I will read them out. And then if we have time, maybe we can, if there's specific questions that we could ask people to ask themselves. But the first one is there any good information on childhood vaccination and the most productive ways to get children in to stay up to date?
Okay. The BC CDC um, booklet that I recommended to you, that the website's there, is a really good source of good information, I think, in language that's really quite accessible. The Public Health Agency of Canada booklet to give to the mothers of newborns is really good as well, provided the language, it depends who you're working with, but it does have 14 different languages you can get it in, and it can be ordered. And I think it's really quite good. The Canadian Pediatric Society website, Caring for Kids, has a fair amount of information on immunization that I think is pretty accessible and pretty useful for people. And full disclosure, I helped write some of that, but I'm retired now. Other people are updating it and doing but those are good things to do. Getting children in and to stay up to date, you need to think of every single way you can do this. Motivational interviewing. You may not see that child at the time of birth in the hospital where they're being delivered, but if you can persuade those hospitals and birthing sites to really emphasize and share how important immunization is, it really increases mothers wanting to go forward. This works globally. It's not just in Canada. There's a study that was done in Uganda where they went to look at uh, how they could improve immunization in this particular district in Uganda. And they were looking at why these particular women in the village weren't having their kids up to date and what were the barriers for them. And then why were these ones in the same village with the same barriers keeping their kids up to date? And the difference was some of them would walk 3, 4, 5 times to the district health center and trying to get their kid immunized. So if it was a stock out, they'd just come back and they'd come back. The other ones just gave up and said, this is too much work. You know, why? Those mothers had delivered their babies in a hospital. But the important part was every single one of those mothers, the mother was an extremist when she was referred, the mother was dying and the baby was dying. And this was an incredibly loved baby and very precious because of things. And in every case, the nurse in the hospital told the mother how important vaccines were for this baby. And so the mothers learned that, just like we showed in our study here, even though those mothers weren't in extremis or anything. Okay. But telling the mother at that time when they're falling in love with their baby, how important it is for their baby's health was really important. So that's number one. Number two, when they do make an appointment, please remind them and make sure that the person registering them for the clinic is welcoming, not being disrespectful from culture or context or language, and really trying to make them understand using motivational interview. What are your concerns? Blah, blah, blah. All the things I pointed out to you that are really important to deal with. And if you do all of that, it's all of those pieces together makes a big difference. And we know we can do better and increase immunization when we do all of those things. There's no magic bullet, but all of those things can help. And make it easy for them to come. Maybe you need your clinic in the evening. Maybe you need it on the weekends. Whatever is going to work for you.
Great.
And if it's a particular subgroup, a religious group or a community group that aren't coming forward, you need to find out from them and their leaders what's the issues that are providing the barriers. And sometimes it's not what you think. There was a study in the UK among Orthodox Jews in northern London that showed it wasn't that they were anti-vaccine, but they had 10 kids and there was nowhere for the other kids to be while the mother brought the baby. And they made Saturday clinics. That's the Sabbath. Okay. I mean, how? So when they changed the clinic day and they provided a daycare waiting area for the other kids who were dragged along, it improved. And the rabbi talked about its importance in the synagogue. It really increased their uptake, but that's very specific to that population.
Right, right. So
You need to think it all through and
check
try and get
in.
the data on why they're not coming.
Right. Great. Thank you. Another question is about the mistrust that kind of developed during the pandemic of the government
Yeah.
And this has increased vaccine hesitancy and or mistrust of public health, as public
Yep.
health is the face of government, was seen as the face of government action and direction during the pandemic. So do you have any input on how to address this and how to try and build trust within our community again?
Okay. There are several things. It's kind of what I talked about before. It is what I talked about before. Healthcare workers are actually seen as being the most knowledgeable and the most compassionate about vaccines. They're trusted. Okay. Study after study after study, even after COVID, study after study after study. You have some power in this. The other problem we had, many of senior government leaders and premiers spoke about stuff that they had zero knowledge on. And remember, I told you need competence as well as compassion. They didn't have the competence. So that pushed them back into being untrustworthy, and everybody got whitewashed by the same brush. So, what you have to do is come back as being competent. So, you need to be sure you're knowledgeable about the vaccines that you're talking about and that you're listening to the concerns in the community writ large, as well as at the individual level. So at the population level, if you know this is a particular problem, then you need to be addressing it. So I was talking to some nurses who work with Indigenous peoples in the North, and one of the questions that came to me afterwards was one of the big problems here was um, overwhelming the immune system. There were just too many vaccines all at once. Okay. And you need to know that that's not a new problem. That's been a problem that's been around since the 1980s. People have been concerned about that. There's papers and studies to show how many antigens are in the foods we eat. Okay. And what we breathe compared to how many are in vaccines. And actually, the number of antigens has gone down as we have refined our vaccines to be even more narrow. So the whole cell pertussis vaccine had way more antigens than our acellular pertussis vaccine. Anyways, you need to find out the pieces that you need to address the community concern in that particular community, and then present it as a question and answer thing and say, because you don't want people to think they're stupid. This has come up as a problem. Can I tell you what? Can I share with you some of the evidence for this? And so on and so forth. And then the other thing is, I cannot say it loud enough. Data tells, but stories sell. So you need to have your stories in your back pocket. So I'm old. I came into practice before we had Haemophilus influenza vaccine, okay? Before we had HPV vaccine, before we had the meningococcal vaccines. I've seen all of those kinds of patients. I've seen children with tetanus. I've seen bad stuff. So it's not a stretch for me to say, let me tell you some stories. They're very powerful.
Great. I have another one.
Yep.
So you mentioned how individuals trust healthcare providers to advise them regarding immunizations. So in your experience, how do you address clinic staff who are vocal about their personal opinions on the vaccine in the community, and they're being viewed as a trustworthy
Yep.
source? And if they don't trust it, then why should the community?
That's right. Let me answer that as a two-parter. That was kind of why I had the slide in there. What do you do with colleagues and the rest of them? You have to speak up. You have to talk about mis and disinformation and how appealing that mis and disinformation is. It's not saying this person, your colleague, is stupid. It's saying, in essence, they've gotten conned. Okay, you're not going to use those words, but this is mis and disinformation that they're telling you and repeating. And it's all over everywhere. We get bombarded with this. Does it make it right? Does it make it good science? No. Okay. And what happens when it gets believed? Bad stuff happens. That's why more Republicans die. In my own way, I'm being sarcastic here. It's Darwinian. Okay. Those who do not believe in science are more likely going to die. Terrible way to put it. But the point that I'm saying here is not that you would say that, but what you're going to say is just what I put onto that slide. You're going to speak up. You're going to talk about what the evidence is. You're going to talk about how important immunization is because kids can be damaged or die without it. You know, I'll give you one little story. When France had their big measles outbreak a couple of years ago, and it's 5, 8 years ago now, everybody thought they would, we have such good medical care now, such good ICU care. Same number of children died, 1 in 1,000, is died in the 1960s with measles. Because you know what? Once the measles virus is in your brain, I can't fix it. I can only prevent measles. I can't fix it once you're infected. And if you're in that group who's going to get bad neural disease, it's done. All right. So that's a powerful story. You know, their ICUs are as good as our ICUs. Now, going back to that specific healthcare worker, if they work in your clinic space, there's other things you need to do. You need to say, our institution supports immunization. At the very least, you need to be silent when you're on the premises on this topic. I don't know what your institution's policies are on that. Okay. When you're outside, social media, that's your own private life. But in your professional life, you need to meet professional standards. And the reason I'm emphasizing that one, Yvonne, is there have been physicians who have lost their licenses and been reprimanded in several of the provinces across the country because of the misinformation they put out about COVID. Because it's not meeting standard of practice. And I think the same thing has happened in the colleges of nurses. So you need to see who's doing this. If they're not doing it at work and it's in their private thing, you know, people can say what they want to say. But in their professional setting and wearing their professional hat, they can't do that. There's if you're a professional, you need to meet the standards of the profession. So that's different than having Uncle Harry, who is, I don't know, whatever he is. He's a lawyer, okay, standing up and saying, oh, I think vaccines are wrong. Well, Uncle Harry is not in the profession, in the health profession. And Uncle Harry, you can say, within health and within the research in health, this is what the evidence says. His expertise is in law, it's not in healthcare. If Uncle Harry's my Uncle Harry.
Yeah. I'm sure he loves that you're using it. Um, so just on that question about like a medical expert, a nurse or a physician or whatever, in their private realm, if they are, you know, representing themselves as a healthcare provider, does that still?
That's a problem. Okay. Even among the College of Chiropractors say that they cannot speak out on vaccines because it is not within their scope of care.
Mm.
Okay. Naturopaths is a bit different because they don't have they're not supposed to do that, but it isn't as clear cut as it is among what the chiropractic college says. If you're a physician or a nurse or a pharmacist, it's really clear.
All right, there is another question.
Yep.
Is making phone calls to parents of children who do not have their vaccination records up to date effective in countering vaccine hesitancy?
So I just gave you the one study that showed sending the letters works. Yes, okay, but you need to do it in a motivational interviewing technique. You are not calling them to be, yeah, 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 you're bad. You're calling them to find out what the issue is. And what you may find out is it may be access, it may be language, it may be past history. They may be afraid. All right. Parents know that needles for their babies isn't pleasant, but they don't know how to decrease the pain for their baby. And there's randomized controlled trials how to do that. Okay. So you need to find out what the issues are and you need to know your evidence and then you need to try to get them in. If they are, and I'm going to say this in a kind of a backwards way, uh, a number of places have immunization clinics for people with special concerns. Okay, either they had a bad reaction last time. There's a clinics across the country that do that. But beyond that, most infectious diseases uh, groups will see patients who have serious concerns. All right. And if you can get them in the door, most of those clinics have a more than 50% chance of catching them up. My experience, and I love this thing, is when you phone the parent, you find out that they have 3 kids under the age of 5, and to have gotten like the 5-year-old got all immunized, the 3-year-old got mostly immunized, and the 1-year-old didn't because it was like you have to dress everybody up to get them out to get it done. And if there was a way we could make that easier or provide, and what's the 5-year-old and the 3-year-old going to do when the mother's trying to get the other, we haven't thought it through in terms of how we could help those mothers. I was really impressed in Nunavut in some of the stuff that's been done up there. They actually go to the homes of some of the families for exactly that reason, because it's more effective to come in and then get everybody immunized that needs to be immunized than to have them all truck out to the clinic. So you need to think about your context. Maybe they all go, I don't know, pick your site. Maybe they all go to um, a, a shopping center and there is a storefront there that's empty that you can work with the shopping center to say, can we have a clinic there where you can just drop in on your way to get your groceries? That's got, you got to be really creative in trying to catch up these children who are not up to date. What I love about this thing is they're trying to find out the why, because the why is what we can't fix it if we don't know the why. Smart question.
Yeah. So one other one, how should we approach mistakes and new information available that changes or modifies our previous recommendations? So how do we convey the nuances and ensure that it won't become a gotcha moment that proves that the public health is wrong?
Okay. There are two things I have to ask you and everybody here. Do you wear the same clothing that was worn 30 years ago?
Although sometimes from a vintage shop.
That's right. But we know it's old. Okay. Everything in life changes. I bet the car you're driving now has more safety features than the car your parents drove when you were a child. All right. It's like seatbelts. There was a time when cars didn't have seatbelts. It's the same thing here. As we learn from the evidence and we learn from the science, we move forward to make it even better. All right. You wouldn't want us to stay still. No, anybody who cares about safety wouldn't want us to have no fences around our swimming pools because we know how dangerous that is, because children died when they fell in and couldn't swim. So we made that law that said they had to do this. We made it a rule that the cars have to have seatbelts in the front and the back. And we made it a rule that the kids had to be in, car seats that fit their age group. All right. Why? Because of evidence. So when we went from 1 dose of measles vaccine to 2 doses of measles vaccine, the evidence said, yep, with 1 dose, we got 90% of the kids who got the 1 dose got protected, but that 10% didn't. But when you give 2 doses, it catches those kids and brings that up to 95%. And that's how you need to talk about what the evidence is, but give the background for it because, oh, I understand that now. I'm rewrapping the information in a way that fits with their beliefs. Nobody wants to drive a car now that doesn't have the safety things in it that weren't there 30 years ago. We want brakes that don't lock. We want brakes. We want windshield wipers that work. I mean, we want all those things. It's the same thing. The reason I was going after clothing, I was looking at, you know, the pajamas that kids wore in the 1950s and 60s were flammable. They
Mhm.
were cute,
Mhm.
but they were flammable.
Yeah.
Okay. We don't have that anymore. We don't let those clothes out.
Yeah.
Same idea.
Yeah. No, and I was thinking about like even at the Prevention Institute when we put out resources, like after a period of time they become dated because people are like,
That's right.
the clothing that they're wearing doesn't fit. Yeah.
Exactly, exactly. And I think the other thing that people forget is your community may be changing. The number of languages spoken in your community can be changing. I don't know Canadian statistics now. I should have gone and looked it up. 15 years ago, our birth cohort was about 300,000. But 15 years ago, we would get about 50,000 kids new to Canada, immigrants and refugee kids under the age of 15 every year. So we had 350,000 new kids every year, and all of our information for the new kids was for the babies. Well, if you came from a country that didn't immunize, and many of them don't, against varicella, they knew nothing about varicella. What is that? I mean, so we need to be thinking about, what does your community look like? How is it changing? What languages do we need to have?
Right. Yeah.
What's the culture? What do they understand? What
Hmm.
don't they understand?
Hmm. Yes, the challenge is you need the resources to be able
Oh
to reach
yeah.
out to the communities and
And that's why you really need to see if there's an ability to develop cute community partnerships where they become committed over the years to be able to do this for you. So a sports team who decides they're going to take it on and do it. One of the fast food restaurants, we're going to take it on and do it. So McDonald's, not that it's McDonald, not McDonald. McDonald's used to put out mats in for National Immunization Month that just said, immunize.
mm,
Those kinds of things really do make a difference. They're not especially expensive. One of the things we did here in Nova Scotia, yeah, olden days. I only came in 1999, but everything wasn't computerized then. Um, the information package you got is when your baby was born, that how to register your baby, and do all of those bits and pieces. They put into that packet information infographic on how important it was to get your child immunized. And that helped.
mhm,
Cost 1 cent because the packages had to be made up anyways, and it
mhm,
cost the copying at that point of 1 penny to copy that.
mhm,
So you need to be really inventive and creative and thoughtful and reminders, and think of all different ways you can shift the system without spending a ton of money to catch those kids up, encourage more people to get immunized on time, but also find out who you're missing and why you're missing them. So if you have a segment of the population you serve and say, my gosh, everybody who lives in this northeast corner doesn't seem to be being immunized. What's going on there? And it may be, as you said, maybe there's a healthcare worker who's really noisy and negative about immunization, or maybe it's that that's a place that's hard to access, or maybe that's very low socioeconomic, and it means people don't have cars and it's hard for them to get to where the clinic is. Could you go to them? We learned a lot in COVID. Moving the clinics to where the people were was
mhm,
incredibly important. Are there other things we can do at the same time? I don't know about Saskatchewan. We don't have enough family physicians, and in our larger urban centers, public health was not giving the immunization. It was being given by family physicians.
mm,
So they have set up a couple of things where if you don't have a family physician, your baby can come here, you can get your immunization, and they will do some of the well child stuff that needs to be done.
mhm,
Okay. So yes, it takes a bit longer than just getting your shot, but weighing that baby and seeing the baby's gaining weight, and seeing that what the baby's diet is, and that they're developing it very quickly, is well worth the intervention in the long term. It's
mhm,
not as good as what it should be, but it's better than nothing. And I don't know, maybe you've got to surf it at Family Doctors, but I doubt it.
mhm. I don't think so.
So that's a matter of trying to pair different programs up. Immunization Agenda 2030 talks about that, about putting the primary care focus and immunization and locking it together so that you're doing more things. So if it's maybe if you're running a flu clinic, you're also going to do blood pressures, so that you're going to pick up undiagnosed hypertension, just stuff that can be done that's going to help people.
Yeah, great. Well, thank you so much.
You're welcome.
That seems to be it for the questions. So,
Good.
thank you so
And
much
this time
for
you recorded.
I did. It's recorded. Yay. So the recording will be available within the next week or so, hopefully sooner rather than later. And that will get sent out to everyone who's registered for the event. So, and also for the previous presentation. So thank you so much for taking the time to speak with us twice, and thank you to everyone who's here for attending. I just want to mention that when the webinar closes, a link to an evaluation survey will pop up, and we ask that people take the time to it'll just take a moment. It's just 2 questions, and that would be great. Thank you so much.